The MRI is $4,000 at one hospital and $300 in another hospital. You're now going to be able to predict gaps in care.
One thing it will never remove is the humanity side of it, the heart of an individual.
I learned more in that analysis than I had learned in 20 years of practicing medicine about my own health.
Well, welcome to another episode of the Leadership Lab with Asbel Montes. Really glad that you've joined us on this. As you've noticed, the last several episodes, we're kind of going down this healthcare innovative. We have a lot of disruptors on here. And today, I'm excited because this is probably my first time on this podcast with someone that was on the payer community side. We've talked a lot about this from the provider perspective. We've had legislators, we've had regulators on here. But today we have someone from the payer community. So Dr. McCoy, I'm going to call him Dan, but
Absolutely.
It's just how I was raised as a Southern gentleman. You always kind of talk. So I may slip into calling you Dr. McCoy, but Dan, I'm just glad that you're here. Right before you introduce yourself, I want to give a backstory because this is the first time I've met you face to face.
Right.
And one of my great friends, Patty McCandless, who does some fabulous work with the health plans, and we met several years ago, was gracious to introduce us. And we were able to have some conversations, and you're a disruptor like I am. And that's the only way that healthcare is going to change is we need some disruption. So thank you so much for joining my podcast here.
Thank you. It's amazing when the word disruptor gets you on a podcast, right? That you're not just a knowledge anymore. It's your contrarian. And I think we're both a little bit contrarians.
Well, you do. So let's talk about that because you have a podcast as well. So I want to give a shout out to that podcast, what you're doing, because I do believe data and doctors and leadership are going to lead the way to innovating and hopefully resetting our healthcare environment as it is, but introduce a little bit about what you do.
Sure. So I do a little podcast for a Substack called Rocket Tools. And, for years I wrote on my blog about healthcare. And then I remember I opened up LinkedIn one day and I thought, people are just saying the same thing over and over again. They're not telling the truth. I mean, they're just not. They're not pulling back the curtain and saying, okay, this is the real problem. And there were a lot of self-interested. I thought, I'm going to take a different stance. I'm going to tell you what's going on. And you'll either like it or you don't. And the establishment, as a general rule of thumb, doesn't like it.
Well, here's what I like, Dan, about that is I'm pretty open-minded to listen to all ideas. I think I can learn something with even people that I have a differing opinion on or a different viewpoint on. And I feel like the dialogue that's happened over the last several years, and I've been doing this for 20-something years, it's almost like if you're in one camp or the other. And rational mind is no longer prevailing, and that's the only way that we can solve some of healthcare's problems right now. It's like the payers are either the demons, the providers are either, and somewhere the patients are getting caught up in the mix, and they're now the problem. And so it's like, where are we on a reset of that? And how are we going to manage through that? And so I'm really looking to have some dialogue around that piece with you, just to say, what's your perspective? This is another perspective that brings it in. This is someone that has years of experience working on the payer side. So for those that are listening today that don't even know who you are a little bit, I'm not sure they can Google or chat. We'll say Google anymore. So now it's Chat GPT, Claude, do something, go in there and kind of but give us just a really quick 30-second, 45 seconds of who is Dan McCoy.
Well, so I grew up in a small town and then somehow ended up a dermatologist, and I ran the outpatient melanoma program in Dallas at Baylor, and I started a consulting company. And the consulting company did storytelling consulting. Way back in the day, we helped companies tell stories. I hate to say I used to have worked with pharma, worked with research back in the day. And one of my clients, Blue Cross, actually hired me out of practice to come help build the strategy space there at Blue Cross of Texas because a little bill had been passed, Obamacare. And so the stodgy Blues company had to kind of move to being multimodal, different products. And I went there and just got lucky, ended up president of the company. And I was there for, almost 10 years. And then about 5 years ago, took an exit like many people do, and still do consulting, still do storytelling consulting, got heavily involved in AI. So today I do about 70% of my time is either on AI strategy consulting or healthcare AI.
So let's do that right now since you did the AI. We talked a little bit about this and how that is impacting the payer, provider, and the healthcare community. I had a podcast here, Kim Brandt, who's the COO of the Centers for Medicare and Medicaid Services. She keynoted one of our user conference this year, a few weeks ago in Laguna. And we did a podcast just recently about how they're using AI and how it's revolutionizing utilization management. It's the reason why they're focusing right now on the home health industry, durable medical. They're even focusing now on non-emergency medical transportation. This isn't a space that I'm in. And they've done it through this diligence that they've hired a company in their chili cook-off that's taken all this AI, and they're finding different outliers through the process. Of course, data tells you just one picture of a story, not everything. But how are you using it? How are you seeing that used in, I'm more interested like in the healthcare, the payer communities, the provider communities. How do you think this is going to revolutionize the healthcare industry over the next 6 months to 12 months?
Well, I think it's going to make huge changes in the healthcare system. Now, a little bit about me. I'm deeply involved. I mean, I believe that I write code every day. So I try to get deeply involved in understanding the technology. I think one thing that's happened in healthcare, particularly with physicians, is that we've walked away. People now they go into an employee relationship. They're not involved in administration. They're not involved in vendor selection. They're not involved in security. So for me, it's really good to get your hands dirty and to be kind of deeply involved in those systems. I do think it's going to revolutionize healthcare. I'm not sure what's going to happen in the next 6 months. I'm really concerned, at least right now, that there's going to be an exaggeration in the haves and have-nots. There's going to be deeply human components that are going to be really important. There's going to be highly autonomous components that are going to be really important. And right now, there's still a large group of people that are just kind of standing on the sidelines. And I'm starting to see a divergence, companies and technologies and people that are deeply getting embedded with products and putting in systems and getting autonomy, growing clinical decision support, ambient learning. And then there's groups that are standing on the sidelines waiting for, this wave to go by. That's not going to happen. We're going to see this wave is not going to go away.
Not for a while, I don't think either. It's interesting to see how some people you can't use it anymore. And I was with just some physicians, some ER physicians, probably 4 or 5 weeks ago in Charleston, and the same decision points that had happened a year before is like, we're not introducing it now. It's a whole different construct. It's how do we introduce it? How do we get in the process of it? How do we speak to it? I spoke about what we're kind of working on even at our own company, because I'm a healthcare tech company, how we've introduced it, how our general counsel, it's constant. We have an AI officer that's constantly looking at putting together processes, almost like we do with compliance or HIPAA. Same exact construct of saying you just need to get involved in this because you're going to be left behind if you don't start adopting it. You brought up AI and ambient AI. We had an outline going here, folks. Of course, we're going to go, and I'm distracting from this or whatever, because as you start talking about
I don't do outlines
my brain
anyway,
so let's talk about ambient AI. That's probably been the biggest thing. And from a clinical perspective, I like all the construct, but we're all watching now some class action lawsuits that are being filed in California, I think, talking about more of a privacy consent. And so talk about how you think that'll to me, that revolutionized the caregiving from the clinician, the doctor, that ambient AI piece. What do you think is going to happen here, and what should healthcare providers and payers be thinking about as we work through this?
Well, let's paint the picture of what happened before AI. You would go in to see your physician, and there's data to show that 80% of the time, the physician would stare at the computer. They weren't looking at the patient. They were looking at a computer. They were doing documentation into Epic or Cerner or one of the systems. So ambient AI, right now, it's the debates on the number, but we'll say 40% or so of practices to 60, somewhere in that ballpark, have implemented some component of it. Every single physician I've talked to says it's revolutionary. It's been the best thing that's ever happened because they can now focus on the patient. They don't have to focus on documentation, and the documentation ends up being relatively perfect. Now, there's some sores here. And when I ask everybody, well, how do you get consent for it? I hear it's all over. People are consenting on a portal. They put a sign in the room. They're having them sign some paper when they come in. There's all kinds of consent issues. And I don't like these state regulations at all. I think the states getting involved is horrible. It's like your cell phone not working in California, working in Texas, I think that's just stupid. But we are seeing, and you and I know we're deeply involved in legislation, that's going to be kind of a big issue. But the advance on ambient learning here, I think, sets up a bigger issue for everybody. The bigger issue is that I think at the end of the day, it runs the opportunity, at least, to empower patients. Because now you can start to build global context around a patient, the conversations, the medical records, the laboratory, and now this conversation with your physician becomes a component of that. And so in the future, when this infrastructure starts to integrate and patients get an opportunity to engage in that surface of AI, it's an incredible opportunity to get very personal with your healthcare. Now, in the short term, most of these systems are geared toward revenue optimization. In fact, 80% of all investment that's coming into AI in healthcare right now is on revenue optimization. It's how can I code better? So that listening that's happening in the exam room, it's probably resulting in a level 4 or 5 code. It probably is resulting in an optimal prior authorization request. Hopefully down the road, it's going to result in whisper technology to the doctor to say, hey, ask about that abdominal pain the patient mentioned last time, or wait a minute, they're allergic to penicillin, don't write that prescription. Don't know that we're quite there yet.
Wow. Okay, my mind's spinning now. You made you just made a statement right now about empowering the patient. AI is really going to empower the patient, and right now we have a lot of revenue optimization models. Just maybe, I'm a disruptor, you're a disruptor. Just maybe some of the pushback that we're beginning to see around the AI, it's really, we may not want the patient empowered because it exposes maybe some of the models of our healthcare. And that's generally as a free market society, because that's what we are here in the United States of America. Just had this conversation with someone else. It's healthcare is a free market society, and we're grappling with that. The moment we empower the patient, they will start to dictate. Once they have more information and resources to them, it's like going to buy a car, going to buy a house. The more information you have available to you, patients may make different decisions and might engage more with their physician and clinician. You're a physician. Where are you on that? Because I believe that physicians have, I was talking to a doc, his name was Dr. Cozy, Chief Medical Officer for Chicago Fire. And he made a statement to me saying, doctors, and I never knew this. He said, we go through 13, 14 years of school at Asbel. We do not have one class on healthcare economics, not one.
Or nutrition, or coding, or IT. We're graduating graduate medical education students today from medical school that have no understanding. We have no AI-directed path in most of the programs. Yale has a little bit of a program, but you're correct.
Yeah, and so
we don't do this for doctors anymore.
You don't. And
no.
So my standpoint is, once he said, we are taking the narrative back. We're taking it back. We've given that away. We know more about the patient. And he's right. I can sit in a room with a white coat. I can say the same exact thing the white coat said. The white coat says it. They listen all ears. And I think that's the issue. We need more doctors at the table like you guys that are saying there is a better way to do this system. Now, I've got a lot of great hospital friends. I've got a lot of great payer friends. I got a lot of great friends or whatever. And I know this probably isn't something you want to hear, but if we really want to fix the system, the data now is becoming readily available. And I've never seen more physicians engaged in the process like I have seen right now. And to me, I think it's great for the patient. And if they have the right leadership, because doctors have egos, like we all do. Love my doctor friends. But if we have the right, I think we literally could do this with more of what you're talking about right now. So my question is to you, have you seen more active engagement from the physician community over the last 5-6 years? What does that look like? What are they grappling? What's some of your observations?
Well, let me tackle the first one first. And let me just tell you up front, this is going to make some of you uncomfortable. And that's okay. I'm going to tell you a couple of things. Do I think that AI is ready to replace the doctor with clinical decisions? No, don't do that. Don't rely on AI to do that. Do I think it's better than people want to admit? It is. Okay. Now, I don't ever let facts get in the way of a good story, but over December, the numbers around the country are about 30 million people worldwide uploaded medical records to the large labs. We're talking OpenAI, we're talking Anthropic. It caught the labs they were shocked about what happened. So much so they had to retool the lab architecture to think about what's happening when medical records and X-rays and EKGs are being uploaded to large language models. And so they developed their own version. So now Anthropic has a healthcare angle, and so does ChatGPT. So you can get into those environments. We have a Rocket Tools, that's our old company. We have a lab. So I thought, okay, let me go deep on this. I'm going to be a doctor. I want to know. I advise people in these systems, and I'm telling people to get involved. Does it work? Right. So I had 23andMe. You probably remember that service went bankrupt, I think. And I downloaded my data from 23andMe. And then I decided it was pretty useful. So I had my entire genome sequenced. And then I was like, I'm not real sure about comfort level of uploading that to Claude or something. So my little team, we built bare metal. We built a server. We actually uploaded my DNA to the server and my functional labs, 167 functional labs, all of my medical records from my doctor, my pharmacy records, all of it into one system. And I have a concierge doc, right? So I'm better than 1% of the rest of Americans on healthcare. I learned more in that analysis than I had learned in 20 years of practicing medicine about my own health. I learned about why my glaucoma is occurring. I understood my risk of getting AFib. I understand why certain medicines work on me and they don't, why one of the surgeries I had in the past worked and it didn't. And I never, ever would have had that global context before. So I know we're not ready as a society to say, okay, diagnose me. But as a dermatologist that doesn't practice a lot anymore, I still do on my phone. And so people send me text messages of rashes and tumors. Okay, now they're all sending them to me after they've checked them with Perplexity. So I think doctors need to be prepared that patients are going to be smarter, and they're going to ask a lot more questions. And many times they're going to be much more right about their treatment and the cancer choice of chemotherapy, and the choice of, and unfortunately for many providers, where they should have their surgery done based on cost. And I think that's going to happen sooner rather than later.
So let's talk about that, because it's moving rapidly, and you're right. This is coming from a physician's perspective, someone that's actually done this. You're in there, you're doing it. And I know sometimes it takes us a little longer as a society, but I don't think it's going to take 10 or 15 years like it generally does. I think this is going to happen very rapidly. This is where I do agree with Elon Musk. I mean, we're going to see some major changes in the next year to 18 to 24 months. So while you're a clinician, I'm also look at this from a reimbursement, a model perspective, a cost perspective in healthcare. This is kind of the answer to the federal government on how the GDP continues to increase because of the healthcare spend. How do we bend that curve? I mean, economists look at this. You don't need to know anything about healthcare. You just know that the trajectory you're on is unsustainable. And so how do you think, and I know this is conjecture, I know we're talking, but there's a lot of us talking about this. I would love your perspective on, from understanding the payer side of things to the provider side of things. And now we're seeing an insertion of the employers. This is something very interesting that Mark Cuban is really pushing right now, which I agree. We have a lot of middlemen in this process that are taking. If you could look in the next year, year and a half, based upon what you know about AI, how it's going to do, patients are going to be more empowered with data. What should the payer community and the provider community be considering as we're fast moving down this trail?
Well, I think it's a great time to be empowered. And we've talked about this a little bit already this morning, that, historically the patient was sort of the connector, and you connected to the health plan to pay your bills. You connected to the hospital. You connected to your doctor. Somehow they sort of just orchestrated this thing in the background. They haven't done a very good job. Okay. And before I start raining on anybody, let me just tell you, my career is a mile wide and an inch deep. I've worked in research, hospitals, pharma. I've done it all. I'm not very well in any of it, but I've done a lot of it. So I've seen a lot of surfaces. It's really easy when you're on the physician side to demonize the payer. But the payer is actually trying to figure out a way to finance the healthcare. So I don't like the idea of demonizing the payer. The payers, don't get me wrong, we'll be happy to go deep on some of the sins of the payer. But on the flip side, the payers often look at the doctors as overutilizers and et cetera. And I used to tell people this at Blue Cross, you've never put your hand on a patient's thigh that just got diagnosed with cancer. So no, you don't understand that world, right? It's not the same. You don't need to pick on both sides. Unfortunately, the employers have often deferred everything to the payers to handle everything. And the payers have kind of sold them out to some degree. They're not advocating, in my opinion, in the best interest of the employers anymore. And if you see me on LinkedIn, and I think Mark does this well too on the pharma side of it, the employers have been taken for a ride, and it's not a good situation for the employers. So I think going forward, every one of these stakeholder groups is going to have to get more involved and understand the system. And I don't think they're going to like what they see when they pull back the waste, because we just talked about AI. Most of that AI work at the hospitals right now is on revenue optimization. And I got in trouble with this earlier in the week on LinkedIn because somebody, when you get attacked on LinkedIn, it's like a debate at the House of Lords, right? I mean, everybody's very polite. It's not House of Commons, but somebody made a comment to me about, like I was standing up saying something about the hospitals, should get better reimbursements and all this stuff. And I'm like, I can't think of a single place in America where we think healthcare should be more expensive. So when you start to think about revenue optimization equals more expense, I have a hard time justifying that to a patient and to an employer.
Well, and it's the truth. So let's get into what you talked about. I think this is a really good to all our friends that are out there that are my doctor friends, because I know there's some that it's all the payer's fault. And my doctor friends need to reset on that. And I think there's probably a little blame that we can take across the board for everyone. But I want to get to the utilization management, because the payers are figuring out, how do we finance healthcare? That's their burden. And the provider community is saying we got to treat the patients. And some of this stuff is not our thing when you see the data. And AI is coming out, and you're exactly right. The provider community and the payer community, one side thinks the other side's going to be, it's going to be everybody when you look at it. And then I want to talk about the one thing that we're not talking about, and that is tort reform. Because in my opinion, a lot of this stuff that I think that AI is going to reveal that I'm excited about is the defensive medicine posture we're in right now, that there's tests that are being ordered. It's amazing how many times it's happening. And a lot of it is defensive medicine, because if they don't do it, then there's this loss, the lawyers get involved, and I think that's another separate conversation we need to have. But before I get there, I want to talk about utilization management. There's a big issue right now about prior authorization, slowing down care, and patients are not getting services that they need, and they're dying, and there's this whole narrative and story that's being told. You have 10 years or more experience about why can you give us a little bit of an insight? Because I always know there's one side, there's two sides to every story, and somewhere in the middle, there's the truth of it all. Talk to us a little bit about that.
Sure. So first of all, let me just let you know in this, no one wants to do it.
Yeah.
Okay. So the idea that the health plan wants to do prior authorization, absolutely not. Nobody wants to do it because it's burdensome. It costs money. It just generates negative promoter scores. So it's like nobody really wants to do that. But it is a huge administrative burden on providers. Whether or not you're trying to write a prescription or order a test or get an x-ray, it injects administrative burden into a system that already spends $250 billion a year on administrative cost. So adding an additional layer on top of that, to me, is useless, particularly if it doesn't result in value. So I love things like gold carding, where if you are ordering a test, you're a good actor, you do that well over time, you shouldn't have to go through that. Now, what's happening right now, of course, is that AI is taking that ambient listing, organizing that prior authorization, so it ends up hitting the health plan perfect. I spoke here in Austin, Texas a little over a year ago, into a group of health plan payers, including medical directors. And I told them, I said, you know what's going to happen? You're going to get perfect prior authorizations coming in. And so now these prior authorizations are hitting a system at one of these big carriers, and they're still being managed. And I don't take this disparaging, but I'll just be honest, retired pediatricians who are working to look over medical policy. Now let's flip it over. Most of the time, they're attempting to pay a claim or approve something based on the fact that this is medical policy, which is based on peer-reviewed literature. The problem is the patient in your exam room is an individual. They're not peer-reviewed literature. They're not a population. So you're seeing a one-on-one, real and raw view of healthcare. When you go to the health plan, when they're trying to do this over a population, they're looking at studies and they're trying to kind of apply this Band-Aid or this kind of mayonnaise kind of cover over all of healthcare. And that's really hard. And that creates the friction that people worry about. So everybody looks right now as that AI is going to revolutionize prior auth. Nah, it's temporary. Because no offense, you can only code a claim up to level 5, and you can only get 100% of prior auths approved. So at some point, you're going to reach a cap. This is not going to be something that's going to have a growth trajectory ever. So to the venture capital people out there, be careful on looking at an endless growth of revenue. But I think it sets up, and I wrote about this recently, it sets up the secondary thing that's going to happen is AI is also going to do clinical evaluation. Should you have ordered that lab test? Should you have done it? Now, you mentioned defensive medicine, but it starts to question medical judgment. That's going to be the issue, not medical policy, but medical judgment. Like, was this a good idea to do a spinal fusion on a 35-year-old before you did physical therapy? Like, what led you to the conclusion that that was the best surgical outcome? And I think that's where physicians may find it uncomfortable, that they've set something in motion, but what's set in motion is going to work on both sides of the coin. It either is going to come from the patient or it very well could come from the carrier.
This episode is sponsored by Solutions Group Services, healthcare leaders' go-to source for maximizing reimbursement and inspiring innovation. At Solutions Group Services, our technology and consulting expertise help organizations recover millions in hidden revenue without disrupting their workflow. Through our flagship AI-powered tech product, Black Ink, we reveal the dollars stuck in insurance claims and give you the map to get them back. Because for healthcare leaders, they know leaving money on the table isn't an option for their organization. Learn more at solutionsgroup.com and discoverblackink.com.
That's an interesting thing that you say, because I think there was a discussion that I was having earlier with someone from up in the Massachusetts area, specifically about the fight between the AI agents. And that's
bot to bot
now.
Right.
And so what you're talking about now it's like, was that the best? So then we've got attorneys looking at that. We're saying, hey, maybe this physician forecasted the wrong because they didn't use an AI tool. They were late adopters. They don't want to adopt to it. And the early adopters are doing it, and they're seeing much more significant results. And so that's where I think the late adopters, that's why I think there's a lot of cautionary saying, don't be too late to adopt, because you might be making decision-making ability that you could be using. And then we get these bot-to-bot wars going on.
It's a tough spot for docs.
Yeah.
Right. I get it.
Yeah.
Because on the one hand, you can't hallucinate yourself into a therapy or a treatment as a physician. But the flip side of it is you can't miss out on global context and connection of dots, that we're only human. It's impossible for, a physician to hold in space all of the data points of their entire panel of patients. And unfortunately, the panel sizes are going to grow, because one of the things that efficiency is going to do is going to take a panel size for a typical primary care doctor and actually make it larger. So if you're not utilizing these systems, I think you are going to find yourself at like, I missed something I shouldn't have missed.
Well, and I think that was a dialogue that I was having with somebody. They were like, Asbel, AI is like a 2000 IQ. Once you train that individual, this person's smarter than you could ever imagine being. And if you train it correctly, it's going to take the kind of the intelligence side of it. The one thing it will never remove is the humanity side of it, the heart of an individual, like that human touch and element which comes in patient care. But it can assist a doctor with something. We're talking about this in the EMS community because EMS, for instance, is very protocol driven. It is driven by the protocols that a physician sets up in their local communities or whatever. Instead of them developing it in their natural brain, this is where AI, I think, is going to come in as well. This is kind of an area that we're warning our own community, saying you've got to start rethinking how you develop your protocols, how your medical direction develops, and how that can be challenged now that every other community can say, well, wait a minute, you've always said I'm protocol driven, or physicians, whatever, and they may sign off on your protocol once a year now. But now this is kind of the stuff that we're talking about that needs to be considered, Doc, working through this, because that's going to revolutionize your payment methodologies, how that goes through it. Is really, we've always talked about capitated care, like here's a lump sum of money to handle your patient population. I'm not sure that's as off base as it was 20 years ago when it was first introduced and everybody said, we can't do that, or they started testing around the periphery. This is maybe something that needs to be considered. Can you talk a little bit about that? Because I think we need to start rethinking that maybe some things that were introduced 20 years ago were just kind of a test, kind of getting you ready for what was to come.
Absolutely. And I'm writing about this right now, so this has not been published,
Okay.
but I'll give you a little inside baseball. Okay.
All right.
And the inside baseball is this, that population health is it's been poorly implemented, mostly because the fact that we just didn't have the technology to really do it. We certainly did not have the payment mechanisms to make it work. And so we put in a lot of systems. Hospitals launched ACOs. That's now a negative word in the employer space because it never really resulted in anything. It was the shiny object syndrome. I saw it in modern healthcare, so I had a modern healthcare moment. I'm going to put it out there. But we're changing things around. The carriers are going to say things like, we've always closed gaps in care. Well, here's the crazy thing about AI. You're now going to be able to predict gaps in care. So I'm actually doing this piece right now, and I haven't published it yet, about Target. And their father ran into, I think, a Michigan Target, and he was mad at the manager. And he said, why is my daughter getting coupons for lotion and a bigger purse and maybe baby wipes and things like that? Well, she was getting those because he found out 2 weeks later she was pregnant. Because buying signals at Target indicated that this individual, in a statistically AI-driven way, was actually pregnant. The father came back, apologized to the manager, and said, I shouldn't have done that. But the point I'm bringing that story up is we're going to be able in the future to start to predict healthcare things. That's going to totally revolutionize population health, because now population health is not going to be retrospective. You're going to be a lot more able to predict, to help someone with obesity if you can intervene before they're obese, or intervene with a diabetic before their insulin levels are out of control and they have diabetes. And so being able to do those predictions with population health is going to revolutionize it. And we're going to be able to do that with signals and AI and the kind of context that we couldn't do before. And that's going to happen with the local doc. So the local physicians are going to have access to that surface to be able to.
So the social determinants of health that we've talked about, all of that, where somebody lays eyes on that, no longer will we have to worry about that anymore.
We have to worry about it, but it's just.
Well, there's going to be data elements instead of somebody going in. As we talked about from the EMT perspective, they would go into somebody's home and they would look and see, well, they're a diabetic, but I see Cheetos on the floor, an open bucket of ice cream. And it's like, this is probably, and you mark it on your EMR so the information can get relayed somewhere. This may not be as big of an issue now because they'll be able to look and see, oh, they ordered that from Amazon. Is that what you're kind of talking about? Like there could be.
I think also, and I think that, it could be presented to the patient. Here's a coupon on how to order it from Amazon. I mean, there's going to be a lot of that sort of connectivity. Now there's a lot of barriers here, but there's a lot of opportunities. And I'll give you a good example. One, the privacy issues. We're going to have to figure that part out. And that's not an easy discussion to figure out where we cross the line between our wearables, transmitting data to the world. I mean, that we're going to have to get over that. But the second thing, one of the biggest barriers to implementing population health has just been the structural mechanics of payment and how do you put panels together? How do you do the math around that? And AI systems are going to solve a lot of that, which I think they're going to solve a lot of things like direct contracting, and they're going to create a lot of opportunities that have historically kind of been in the realm of the health plan. If I was running a health plan right now, I'm not anymore, but if I was, I'd be nervous. Because I think there's a lot of things like, everything from, taking care of credentialing your doctors to managing medical policy to managing payment of claims to building networks. A lot of the things that make you valuable as a health plan are going to have a new surface in which to operate with technology. And that's going to bring physicians and payers kind of in a different part of the world. I think you're going to be able to see people engage with the healthcare system in a different way.
You know that you say that, you just triggered a conversation that I had with somebody yesterday about a very large health plan system on the West Coast, left to be unnamed, and they literally laid off their entire contracting department, and they went to the use of AI, and all of these providers started getting new contracts because they were using something, and everybody's confused in the provider community. But obviously the payer has some type of data that they were able to kind of eliminate out direct contract. You're already starting to see it. It's very interesting, that direct contracting approach, and I think it's got providers kind of confused through the process.
Again, this will make potentially warning, a flashbang warning. This may make people mad. So, I'm a huge advocate of transparency.
Yeah.
But transparency's table stakes. Transparency didn't do much. Transparency didn't help me. I look at my scale every morning and I still don't lose weight sometimes. The transparency is important. I have to know my current weight, but it's not necessarily going to make a difference in me. What's happened in healthcare pricing particularly is that the opaqueness has led to higher prices. So you've got, the idea that we don't know what things charge and what the price of something is. People always tell me, Dan, we have this huge cost problem in healthcare. We don't have a cost problem. We have a price problem. There's a big difference. We have a price problem. We price our services in many areas too high, or they're in a confusing thing. There was an article, just to give you an example. This is an interesting example, and I have not reviewed this, so just warning, I have not done a lot of detail. I read it in my morning reading this morning. But the Baker Institute just released a report on the price of health insurance for state employees in Texas. I think it's like ERS, UT, Texas A&M. Okay, Texas A&M was like hugely more expensive than UT. They're both on the same network. They both have the same product. So why is that? There's opaqueness occurring between state agencies over this. So imagine employers that wonder why the MRI is $4,000 at one hospital and $300 in another hospital. Or that is the kind of, I think, confusion that has led to this opaqueness around cost that's going to be really kind of cleared up a little bit by AI. And I don't know that providers are ready for that.
They're not. I can guarantee you they're not ready for that. And that's my whole push. And I think why we're seeing some pushback initially regarding AI and not adopting AI, and this fear around AI, because it really has something to do with more of, do we really want that transparency side of this? I know this was a part of the initiative of Trump 45. I remember talking to Deputy Secretary Cargan. This was a really big push by their administration, thinking if we would become more transparent, we would get the information out. That's why they came up with all the pricing transparency rules from the hospitals to the payer perspective, get that piece of it. We wouldn't be having this dialogue around no surprise billing in the patient and getting all these balance billings around ER. Got really involved in that space. And then when he left, that kind of went on the back end, and now it's taken forefront again. So you're exactly right. I think it's going to expose things that people aren't even ready for, that I think employers are going to see, and they're beginning to see. That's where I think the biggest impact can be, is with these Fortune 50 companies taking back control of the healthcare dollars that they spend. I'm a company, and I have nowhere near, but I know when we look at our spend for our employees, I can only imagine the savings that you'll see. And I've talked to several large employer groups, that those that have gotten involved, but some of them have faced sorry, we can't share that information with you. Or there's this pushback of getting the information. It becomes muddy. And so I'd really like your take on that perspective. Is there is this really push from the employers, getting the employers involved. And the only reason why I've taken note of it is because of all the surprise billing that we've done, how predominant ERISA is, how the employee, and I'm thinking if they would get louder, it's interesting the impact that they would have on this. And what's your background doing consulting? I know you work with employees, you work with payers. Is there kind of a move to move that way as well, to put pressure on the system to fix what we've got going on?
Oh, absolutely. I mean, the employer, just looking at the national employers in the last year, I mean, we're seeing rates and trend that's anywhere from 9 to 20%, depending. I mean, that's incredible. I mean, there's no way that a normal margin in a business can absorb that kind of trend growth in 25% of your overall expenses. It's just impossible. I did just get back from the National Business Group on Health, and not throwing shade. I hadn't been in 7 years because I had just not been back. It was in New Orleans. Great meeting, learned a lot, not a lot new. And it really annoyed me because I'm stepping back here, meeting with employers, meeting with providers, meeting with payers, again, mile wide and inch deep every single day. And I'm seeing DEFCON 1. Okay, I'm seeing people people are worried about getting laid off from AI. You should be worried that you're going to get laid off because of healthcare cost increases. That's going to be what's going to drive a lot of margin decisions. It's not AI, right? That's going to be the issue. So I'm really concerned that we're not really moving fast enough. But back to the transparency part of it, I'll tell you, if you get a moment, I'll tell you a quick story. Because one of the things is, you as a small business, I have a small business too. In our healthcare, our biggest determinant really is network choice and cost. That's our big issue. For bigger employers, it's a bigger issue. It's like, how do we recruit people? How do we retain people? How do we find the best doctors and the best hospitals? So we did an experiment. Right. So we asked ourselves, we wanted to put ourselves, our little company, if we were a business consultant and we were advising a big health plan, and we wanted to start to ask some questions. So if you're having a baby in Frisco, Texas, how do you pick the hospital where you deliver your baby? Well, you're going to pick it based on what your OB-GYN recommends. How do you pick your OB-GYN? You're going to pick that based on what your friends recommend. You're not going to go on to the payer portal and log into Blue Access for members and figure out which is but you're not going to do that, right? And then the second thing is, how do you pick the best hospital to put in a network? I won't name the names here, but we did look in Frisco and we looked at knee replacements. So let's just pick a thing. So we built a little software system that connected to Seraph Health, which is a machine learning company out from California, fantastic group. They clean this machine readable file data, and we ingested it into our AI models. And then we got carried away. We said, okay, let's look at Google. Let's look at Yelp. Let's look at Indeed. Let's see what employees are saying when they're leaving the hospitals. Let's look at geographic distances. Let's look at Facebook, Instagram, Reddit. Let's figure out which hospital is actually the best. And what we found was that one hospital in knee replacement was $6,000 cheaper in Frisco compared to the other hospital. And then when we looked at Google reviews, we found it actually had decent Google reviews compared to the other hospital. So it looks like that's a no-brainer. Really no-brainer. But when we dug in, we found really interesting things, like they never responded to a bad Google review, that their Yelp scores are actually worsening over time, that the Indeed data shows that all the employees that were leaving says management doesn't care about their employees and doesn't care about what's going on. Their quality scores are actually dropping. So if I'm recommending, to an employer which hospital to pick, do I really want to pick a hospital that's got bad scores from management, bad quality scores on a knee replacement that saves $6,000, but one bad knee replacement is a $50,000 readmission? So I think the determination for these larger employers, the data is going to really pull back the curtain on some of these decisions that the broker community, which incredibly needs disrupted, is going to walk in and just say, pick this one based on cost. No, I don't think that's going to happen anymore. I think you're going to start to see a lot more opening up of the kimono and saying, here's how you pick a doctor, here's how you pick a hospital. And as a doctor and as a hospital, I think you better be prepared for that.
And what about consolidation because of that? So I'm listening to what you're saying right now, and all of this information now is taking it all together. And how I want to look at it from just the provider community is, if I have all of this and I've got some of that, might be cheaper for $6,000, but if I'm not really sure what the outcome of that knee replacement would be, because if it's done incorrectly, now I've got to wind up having to go through, as I'm just thinking about it from a patient's perspective. Do you think this is going to force some consolidation to take a look at look behind the curtain in the mirror? Because now it's going to be around for everybody to see. It's no getting around that.
Hell, I don't know what we would consolidate. I mean, we've done such a poor job in this country related to consolidations in general. Back to I think the Affordable Care Act, passed the bill that prevented physicians from owning hospitals.
Yeah.
And the biggest fear is that physicians would, self-refer. And so that we had to eliminate that risk. And you saw all of this investor capital that was ready to build hospitals around the country just evaporate because now the federal law wouldn't allow it anymore. And I think over the same time period, just in the state of Texas, we've seen 47 hospital mergers. Most big systems big communities today have one or two hospital systems. We've seen 15 to, can't remember. I think we've gone from 37 to 47% of physicians are now employed by hospitals. On average, the physician's not compensation, but the cost related to that care goes up about 15 to 20% every time a hospital recruits a doctor. I doubt the physicians are being paid anymore within that system. The quality numbers have not gone up, and none of it has had any FTC oversight whatsoever.
So let's talk about that. I know I'm excited. Like this is, I know, disruptive or whatever, and I'm going to talk about it anyway. So I have a really good friend. They run a independent physician type association called Indomed. You might be familiar with them. Dr. Brueggemann's very, very, very involved. He's an orthopedic surgeon from the San Antonio area, does a lot of stuff on the national level as well. I know there's several that have kind of talked about. I brought on Dr. Brian Miller, a hospital internist from Johns Hopkins. We had a conversation on one of our podcasts around should physicians get more involved? Was this an unintended consequence of the Affordable Care Act? I understand maybe why they did it, but to me, there's other safeguards that you can put around this. To me, this seems like a lot of issues around self-referral. That really, are we really getting into that now when we have hospitals putting in different centers and they're doing a lot of different, you can go to one hospital system, but you need cardiovascular work, you got to go to another and they transfer you to another because they're specializing that. Should physicians get more involved in owning healthcare?
Yes.
To me, I think it's
because I'll tell you why. I probably wouldn't be as passionate about it if the system worked today. But this system doesn't work today. Now, we've got
to do something different.
And unfortunately, it's a little secret. We're a little immune from it sitting up here. Because we are.
Yeah.
And I know it because we know people.
Yeah.
But today, we've gone through mass consolidation, huge health systems that have gobbled up. And hospitals are a big part of the problem. I'm well known for throwing shade at the hospitals because the hospital prices are out of the control. Their margins are out of control. And I don't think they've done anything to improve service access and care. I don't. And I can look at it today. If you get sick in a peripheral emergency room in Austin, Texas, I'll almost bet you $100 there's no bed available downtown. I'll almost bet you that. Now, I know that because I deal with it. I have friends call me and say, hey, I'm in a neighborhood hospital that supposedly had cardiac care available. But they don't. They have a PA available that, is a cardiologist that sends out there. But they don't have any cardiologists available. They don't have any technology. So they need to be airlifted or transported downtown. No beds available. So they have to get readmitted through the ER if something like that goes on. So we haven't done it. We're paying premium prices, but we're not getting premium opportunity. I think doctors could do that better. I really do. I think if you had an orthopedic hospital that specialized in orthopedics and we'd allowed that system to grow, they could do orthopedic trauma too. And we would find ourselves in a different spot. I think competition is actually good, but we've totally removed it.
I'm convinced more and more since we started this. This is the reason why we titled our technology conference Data, Doctors, and Leadership Through the Eyes of the Patient. I'm convinced that if the doctors can marry the data and the healthcare economics together, that is the disruption that we need. Now, I've got lots of friends who are hospital executives. They're MBAs from Ivy League schools. I get it. They're smart. But for some reason, we have compartmentalized the physician, the clinical. You just take care of the patient. We know how to run a business. And I think that's been, unfortunately, to the detriment of the healthcare system.
Well, obviously, I agree.
I know you do.
I'm probably biased, but yeah, physicians need a seat at the table. And a voice heard. And you should listen to them when you start to make your business decisions.
And I think we just need to be open-minded right now. I think if we would get together, we're smart Americans. Good governance is consensus governance. I don't always have to agree with with what you say. I don't always have to agree with. There's conversations I've been having, and there's some things that you're talking about today I don't necessarily agree with, and that's okay. But I'm hearing, I'm listening, I'm learning. I'm learning something new from that perspective. Let me talk about, I'm going to kind of pivot to the last few things that I want to talk about, because this is a lot of information to digest. I just want to get the dialogue moving, get people to talk and start listening to each other. That's how we solve problems. We're all smart. You can't have the acumen that we have here to have this trajectory that we're going unless it truly is just about the money. And I don't want to believe that. That's what I don't want to believe, that this is literally all about the money. Who cares about the patient? Who cares about anyone else? That is not who we are as citizens of one of the greatest nations in the world. I refuse to believe that. There are maybe people that are there. That's fine with me. But from my perspective on leadership, I believe that most of us are gracious leaders. That doesn't mean that we don't see things through the process to understand it, but I refuse to buy that all we care about is the money. There's people out there that do, but I refuse to believe that just in general. I think venture capital is needed in healthcare. I think private equity is needed in healthcare. I think for-profits, nonprofits, I think there is a space for it to make this thing work, but we have the wrong people leading it, and I think the physicians need to rise up, understand the healthcare economics, partner together, and coupled now that we have data. We now have data. 20, 25 years ago, we couldn't say because everything was disparate. We tried it with the HIEs. There was all this other stuff coming to start the concept. Now, artificial intelligence, in my opinion, has been the game changer. And now if we can couple the smart people like you've dived into it. You're a physician that's dived into the AI. Now I've got an authority speaking through the information. So this is a great thing that leads into my last question. If we had no impediment barriers, I've got two questions for you. One was the One Big Beautiful Bill, and there was a lot of concern. It passed out of the House around the feds for 10 years would govern the laws, and I'm paraphrasing this, would govern the laws of artificial intelligence and how AI would be utilized on a national. So it would be more national instead, not to the states. The Senate got it, became a really big issue about states' rights, an issue related to that, and that kind of came out and it left it to the states. And now we've got to deal with 50 states and their laws. And you mentioned this at the very beginning when we were talking. I want to understand your thought around that, because I've heard both sides of it, why it should be federally for 10 and then some why. And I'm kind of in the middle about it. I'm a big states' rights guy. I want the government, the federal government, out of my business for the most part. I want it more to the state. And if I don't like what the state's doing, I can move to another state. That's kind of my process with it. I can influence that piece of it. But tell me where you are with that, because you made just a few statements. I'd love to hear your perspective on that.
I think I'm a states' rights person too.
Yeah.
But there's just certain cases where it, as a country, it doesn't make sense. Okay. If you're driving from here to Arkansas and Arkansas decides we're only going to sell diesel, your car doesn't work anymore. So you can't go to Arkansas. Your cell phone doesn't work when you land in the state of Colorado because they're in a different system. Your CPAP machine doesn't plug in correctly in Georgia because they're on a different grid system there. When we talk about the fabric of infrastructure, AI is becoming electricity, natural gas. It's becoming telecom. It's becoming to things that today people are going to see as a connectivity layer, internet layer. That's my problem. That's the reason that I think it probably doesn't need to be legislated on the state level. Not that many of the state laws that we've seen have bad intentions. I don't believe that. I just know that from somebody who has to navigate the infrastructure and interconnections between them, it will put another layer of opaqueness, another layer of administrative burden, another layer that could get in the way of a patient decision-making, which I don't believe the system can handle.
So it's the inter and intrastate commerce construct. That makes total sense to me. Like that's kind of that's an aha moment. The last question I have for you is just kind of something a little bit more. I mean, we've gone kind of deep through this process, but let's just say we don't have to worry about regulation. We don't have to worry about legislation. What are one or two things that, I know you're working on some stuff probably here in the state of Texas. If you had to remove all barriers, what are one or two things that you think could rapidly help our healthcare system?
Well, I think that back to the decision making, to me, it's always been pretty simple on a healthcare decision. I don't care if it's legislation or contracting or whatever. Is this in the best interest of the patient? Not is it the best interest of our company or our practice or the hospital or our state or whatever. Is it the best interest of a patient? Is a patient going to benefit from this particular decision? And if we would start to put that lens on all of our decisions, it would have a big impact, I think, on our decision making. We put that lens when it's personal, but we somehow talk in the abstract when it's about population health. I think today, I think the biggest thing that would probably benefit people is to have more open communication and dialogue about what the rules are. Bring all stakeholders together at a meeting. Realize that you can have differences of opinion and you can still find compromise and find the right answer to a solution. These are not easy questions that we've talked about today. They don't have easy answers, and sometimes I'm always really good about being definitive, but I'm not always right. And I understand that. And so I think bringing that kind of conversation and dialogue together is the best thing that can happen to healthcare.
I think the more we do, that'd be great. What's one thing that keeps Dr. McCoy up at night?
I think the thing that keeps me up at night is that my kids are growing up in a system that I believe will be detrimental to their healthcare long term. And again, I don't know how much of this is playing a role, but I look today at the explosion that we're seeing in cancer in young adults, and these drugs that are often chronic that cost $250,000 a year. So on the one hand, I'm excited because we're discovering new drugs and with AI especially that are helping to be very precision medicine. I mean, concierge medicine may be a genetic therapy in the future, and that's just amazing to me. But I worry that we're going to have a system that's going to be paralyzed in its ability to pay for that. And I want my kids to be able to grow up happy and healthy, and that worries me.
So one fun fact or whatever about, I asked this of Kim Brandt or whatever, and she baked cookies or whatever, but I know a few things with you and chocolate. Tell our audience right before we sign off on here, tell us how you got involved in chocolate and all that fun stuff.
Oh, so 30 years ago, I started to make chocolate for a friend of mine for his retail store, and I got lucky. I sent some emails out to some great chocolatiers in the world, and they all responded, and they said, come learn. And I was an anomaly as a dermatologist. They said, you're not a pastry chef. And I said, no, but they took me in. And what I didn't know at the time is that these people turned out to be some of the best chocolatiers in the world. And so when I left Blue Cross and, had some more free time, I'm not good at very much, but I'm really good at hiring people. And I found this great team of people in Fredericksburg. And I said, okay, I'll put this together and we'll build a chocolate company. So we built Hill Country Chocolate in Fredericksburg. And it's been a great run. I mean, we're on our 5th year and we've become one of the national experts in wine and chocolate pairing. And it's been just an absolutely fun thing to do. And so I go talk about AI and things that move the world around healthcare. And nobody ever asked me anything except about chocolate. So,
well,
what I'm known for.
I know. It's like the one thing that we did not talk about the whole time, but I could not resist talking about you because number one is I love wine and chocolate personally. I know my wife loves chocolate, and so I'm excited about getting to taste your chocolate as well.
You.
But Dan, thank you so much for joining us today as well.
Thank you for what you do.
Appreciate it. And if you want to subscribe, take a like through the process, share this, the more exposure it gets as well. And Dr. Dan, just one little thing, how can people access you? We'll make sure that it gets posted and whatever.
Find me on LinkedIn, and then I have a Substack, so you can go out to Substack and find me there because that's where I usually put videos. I also have a little fledgling YouTube channel, but most of what I do is on Substack.
On Substack or whatever, and then to follow him along or whatever. Thank you for joining us here on the Leadership Lab.
Thank you.